Hey, good morning, everyone. Welcome to the Echo Clinic Pain Management. Before we get started, I just want to see, does everybody want to go around and introduce themselves so we know who's on this morning? So why don't we start
with Sue.
Yeah, top right, Sue.
Hello, I'm Sue. Can you hear me?
Yes.
Yes, we can.
I'm a internist with my own practice in Minden, Nevada.
Well, thank you for joining us this morning.
Okay, thank you.
The next to
Krista.
Krista, you want to introduce yourself?
Hi, I'm Krista Secord. I work as a nurse practitioner here in Elko, Nevada.
Hey, thank you for joining us this morning. Becky.
Hi, my name is Becky Bailey. I'm with Nevada Rural Hospital Partners.
Hey, thank you for joining us, Becky. Alan.
Yes, I'm Alan Fisk.
What's the protocol for how long?
Technology for the School of Medicine here in Elko and throughout the state. If you have some technical issues with Zoom, why please give me a call.
Thank you.
Barry, Dr. Cole.
Dr. Cole.
Yeah, good morning. Barry Cole, Reno, Nevada.
Hey, thank you for joining us, Dr. Cole.
Tyson McBride.
Yeah, Tyson just up, physician assistant up in Lovelock, just started.
Hey, thank you for joining us.
Yeah.
And who all do we have joining us from Ely this morning?
No way.
Ely, are you there?
Good, thank you.
Everything's ready? Thank you. Good, thanks.
Dr. Chuang.
Yeah, Rita Chuang, Family Medicine in Henderson, Nevada.
Excellent. Thank you for joining us.
Dee Maniko. Okay, might not have audio. And Kevin Flynn.
Hi, I'm Kevin Flynn. I'm the Director of Pharmacy at Northern Nevada Medical Center.
Hey, thank you for joining us. Well, perfect. Appreciate your guys' time this morning. We always want to make this more of an interactive session, so at any point if you guys have any comments, questions, or want to make a point, please don't hesitate to speak up. To start out, does anybody have any cases or a patient situation that they want to discuss this morning?
Doc, a long time ago, gosh, it probably been 6 months ago now, at one of the echoes, I can't remember if it was you or somebody else, mentioned that there was really only one muscle relaxer that worked, and it wasn't Soma.
Oh, okay, yeah. So basically, there's actually three.
Do you have an opinion on that? Is there really only one that works?
Well, actually, if you look at the medical studies, there's only 3 different muscle relaxants that actually truly relax muscles. One would be the class of benzodiazepines, which I try to avoid due to the chemical dependency and the potential addiction part of that medication. The other 2 are baclofen and tizanidine. So yes, that was probably me who raised that point previously. But those are your three medications that actually have shown in clinical trials to relax muscles.
Thank you.
You're very welcome. Anybody else have any questions or a case or want to discuss anything before we get started?
I have everyone on mute, so please, if you do have something, unmute yourself with the icon in the lower left corner, or if you are joining us by phone, it is *6.
Okay. Well, why don't we get started on my slides, and as we go, people have questions. By all means, just stop me as we go. My presentation today is going to be the 12 steps of proper opioid prescribing. I made this presentation about a year ago, and I've tried to update it recently. But more importantly, as we go through it, with the new Bill 474 that got passed, I'll try to throw out, things that will help you be compliant with that bill underneath the 12 steps of opioid prescribing. All right, next slide. So the first step to proper opioid prescribing is to have an assessment of a patient's pain. And I think, we probably all agree here that probably the number one scale used to assess pain is the VAS. How many people here love the VAS? Yeah, it's a scale that not everybody likes. It's very subjective. It's not objective. So my clinic, we try to use the Minkowski scale. Has anybody ever heard of the Minkowski scale before? Basically, the Minkowski scale is an observational scale. And so it basically gives a description 0 through 10 on what a person, how they would behave or how they would look if they were in, different stages of pain. So 10 would be unconscious, unable to communicate and tell you about their pain. So most patients who present to your clinic, if they are in severe pain, would probably, the worst case scenario, they'd be a 7. A 7 would be that they're able to communicate their pain complaints, they look uncomfortable, but they're able to fully tell you how they're feeling at that moment. And obviously, like a 0 would be, completely normal, no signs of pain at all. I think before I've given you guys the Minkowski scale.
Yeah, do you want me to show it?
Sure, if you want to pull it up, we can take a look at it. So as you can see on the ECHO website, we have a link to it. So if anybody wants to use this, they're more than welcome to download it off of the website. So let's look at another example. If a person is a 4 out of 10, it says that the pain it can be ignored if you're really involved in your work, but still distracting. You only need to take mild painkillers to remove the pain for 3 to 4 hours. So it's a very descriptive pain scale, and I think it gives more objectivity to your charting when you're describing where patients are at with their pain. Any questions on the Minkowski scale? Okay. Another assessment of pain that you can use is the FACES, and that's usually more for children. Children really can't communicate pain, and so therefore the FACES scale is a good way for you to document if you're seeing a minor and if they're having pain. Any questions on the assessment of pain? Okay. Number 2, or next slide. So step 2 would be a clear documentation and the rationale for opioid use. So typically you'd want to say that patient probably has chronic, around-the-clock pain. That's usually the nomenclature that the medical boards are looking for when you're treating chronic pain. I think it's also important to document that the patient has an inability to function, or they're having difficulties doing their daily activities. And you probably also want to document that they have a poor quality of life, or their quality of life is not good due to the pain interference. Step 3, you want to clearly document the beneficial clinical response to opioid use. So the typical things that you'd want to talk about are how it decreases the patient's pain, increases their function, and improves their quality of life. And I think the biggest one here is probably the increase in function. If the patient is able to do more, carry out their activities of daily living, then it's probably beneficial that they stay on opioid medications. I think a lot of times, you see patients and, they'll tell you that their pain is a 7 out of 10. You put them on opiates and a month later their pain is still a 7 out of 10. I think a lot of times patients are afraid to say that their pain is less out of fear of the provider decreasing or taking away the pain medications. And so a lot of times I think patients will overplay the VAS. And so I think that's why it's more important to look at something objective and discuss their function. Are they able to do what they want to do during the day? Any questions on step 3? Step 4 is establish goals of opioid treatment and review the goals. I think this is a good point to make, that when you're first starting patients on opiates, you may want to take 3 goals that the patient wants to achieve, and you may want to file it away. And then 3 to 6 months later, you'll probably want to pull it back out and discuss it with the patient. I think a lot of times patients don't realize what they're able to accomplish while on the medications. I think a lot of times they'll come in and complain that things aren't going well, but if you're able to pull them out and review with them, you'll probably find that they're able to accomplish the simple goals. Now, and that's what I want to get at, is these should be simple goals.
Yes.
You know, it may be, hey, I have a difficult time walking from my house to the street to get my mail. And that could be a simple goal for a patient. I've had patients come in who say, hey, my daughter is getting married in a couple months, and I want to be able to walk her down the aisle without difficulty. So these goals should really be simple and obtainable. They shouldn't be, oh, I'm going to go back to work at 40 hours a week. I mean, that may be for some patients, but you want to make these real simple and easy goals to obtain. I always tell the story that there was a pain doc that I met down in Atlanta when I was doing my pain fellowship, and his goals for patients was weight loss. And to him, if patients were losing weight, that meant that they were being, that their function was increased and they were able to do more during the day. So every month, he would actually weigh his patients when they came in for their medication refills. And if at any point patients were gaining weight, not losing weight, then he would consider taking them off their pain medications, because they obviously, the patient wasn't being, you know, their function wasn't increased. So I don't know how people feel about that. I thought that was kind of a cruel way of measuring function. But I'll tell you what, those patients were always ready for their weigh-in when they visited that doctor. So yes, you definitely want to establish goals, periodically review the goals, and make sure your patients are obtaining the goals. And the CDC guidelines discuss that if patients aren't obtaining the goals, then you should, that's almost an endpoint for discussing weaning or discontinuing the pain medications if they're not reaching their goals. Any questions on that point? Okay. Step 5, you want a current and updated medication list. And why this is important is I think that, you know, your patients, typically with chronic pain, are very disabled and they have multiple comorbidities, and they're going to be seeing multiple other doctors. And you want to make sure you know exactly what they're taking. The biggest goal of this is to prevent adverse drug reactions. The last thing you want is your patient to end up in the emergency room with an accidental overdose because their medication regimen had recently been changed. Things to really pay attention to would be, you know, CNS depressants. You know, did somebody recently start them on, you know, Ambien? Did somebody put them on a TCA? You just want to make sure that your patients haven't been started on a medication that's going to cause an interaction with the opioids that you're prescribing. Another one would be benzodiazepines. When I'm checking the PMP on my patients monthly for med refills, I think you'd be surprised at how many times I've caught a new prescription of benzodiazepines being prescribed to one of my patients, and the patient didn't know that that was not a good interaction. And so a lot of times I have to have that discussion that, hey, you know, in the last 30 days since I've seen you, you got started on a benzodiazepine. Why is that? Who are you seeing? Why was that started? I don't think there's any other medications that we'd be concerned about besides those. Oh, antibiotics. Sometimes if a patient gets started on antibiotics, that can change serum levels of opioids in their system. And so that may make the medication more readily available in their blood, may even spike the opioid levels and cause them to have an overdose. So you got to be careful. Even, you know, a medication like an antibiotic that you would not think would cause that type of reaction.
Watch out for the acetaminophen also. When compacted with the opioids, it has a real detrimental effect on the liver and the kidneys. Some people are looking at 4,000 milligrams as the cutoff, but around 3,000 is really very risky, especially for people who are naive to that drug. And then when we're looking at opioid benzos and muscle relaxers, that's like the holy trinity. That's where we get a lot of the overdoses. There's just a new statistic that came out that said that there was 63,000 drug-related overdoses last year, which is more than everybody who died in Vietnam over the 11 years that we were there. So when we're looking at the combinations, we have to be real careful about what else is happening with the body. For example, if they're taking Percocet 10s and we close down the liver and the kidneys, they're creating a toxic environment inside where they're dehydrating the body, and also because of opioids constipation impact, they're not able to release or expel. And so that toxicity is getting larger and larger. However, they're not aware of it. And so they're nodding off and not even aware of what's going on in their body. So all of the different combinations like Dr. Patterson bringing up is really important, especially when he's talking about goals, setting up a short-term goal and recognizing that a lot of these medications are wonderful tools for short-term, but in long-term, they create a real detrimental effect.
Dr. Chrysler, do you have a question?
Yeah, back up for a second. I had a little problem getting my audio. When you talked about, improvement in activities or goals or all that, did you ever consider having specifics, not just, for example, maybe a booth where you check reaction times, eye movements, speed of, compliance, understanding words, or, something that's really objective, that they are showing improvement, not just reporting it.
So our clinic right now, we're trying to look at different assessments to track function. And I think we're breaking it down by body part. We're breaking it down by neck, for neck pain patients, lower back for lower back issues, and then upper and lower extremity assessments. And so my physical therapist, her and I had a conversation. We talked about different assessment tools that we can use. So what we're looking at doing now is for all patients who say come in with a lower back complaint, we're going to use the Oswestry Lower Back Disability Scale and the SF-36 as a way to track outcomes. So we'll hopefully get those assessments done at the initial appointment. And then let's say they do physical therapy. After they finish physical therapy, we'd like to redo those assessments to see if there's improvement. And say I do an epidural, or I do like a radiofrequency ablation of the lumbar spine, or I do some other type of intervention, we want to also see what the, before that procedure is done and after they heal from that procedure, what the outcome is. So yes, our clinic is definitely looking at different assessment tools on tracking outcomes. I think there is some device that can track, I think it's an eye tracker that can, look to see if patients are impaired while on drugs. I've heard about it, but I've never seen it or tried it. But you're correct. I think there are some tools out there that are available for providers.
Well, we used to use a long time ago when I was still active, very active in occupational medicine. We used a Cybex machine, which could document range of motion and all of that, and it was pretty difficult for the patient to, repeat if they were not honest. I mean, the machine just, tracked it very accurately. And we just asked them to do the same thing over again, come back to it again. And it was pretty obvious who was not being very truthful. So there are machines out there in occupational medicine that can give, and then, you know, like airline pilots, you put them in a simulation booth, you can tell whether they're can do the job or they can't do the job.
Correct. You know, I think you're right. I think, you know, especially with work comp patients, you know, a functional capacity evaluation or you have different measures to see if the patient's putting a full effort in, right? They see changes in their vitals, their pulse increases with activity. And you're right, they have the hand grip test to see if the patient's consistently giving a full effort. So yeah, there are objective measures out there, you know, physical ones that, you know, you guys with occupational medicine have used to track work comp patients over time. Does anybody else want to add to that or have any suggestions on different objective measures? Do we have another question?
Yeah, could you address this question by Dr. Cole?
So Dr. Cole has posted a question that says, last week there was an announcement in the medical literature that gabapentin and pregabalin may cause synergistic sedation and therefore respiratory depression. What do we do now? Almost everyone with pain who comes into a pain clinic eventually gets started on that type of medication. If you're looking, I guess, at that type of medication, usually I'm thinking those are medications to treat neuropathic pain. That's typically what I'm looking at, starting those medications for patients is around the clock neuropathic pain. I guess an alternative to look at would be Cymbalta. That would be a medication that helps neuropathic pain. Or alternatively, maybe a low-dose TCA at bedtime. Those would be the alternatives that I would look at. Anybody else have any suggestions? Dr. Cole, you have a comment on that?
Yeah, this is Barry Cole. If you hear my grandson crying in the background, he just took a header. The point that I wanted to bring up is that a lot of family practitioners will start a gabapentinoid, particularly Neurontin, Lyrica, for lower back pain. They're talking like 60% increase in odds ratio of opioid-related deaths if your patient is now on concomitant opioids and gabapentin. Yeah, I get TCAs are great unless you have kids under 5 in the house, because if they swallow one of those TCAs, they could be a direct admit. If you look at Cymbalta, which I actually helped launch for all of its pain indications, it's great for more centralized pain, but if you have a lot of neuropathic input peripherally, that is kind of where we expect the gabapentinoids to be useful. And my impression is most people with chronic pain have some elements of neuropathy, even if we're not calling it a classical neuropathic pain syndrome. So the advisory from PLOS last week was start thinking about your opioid gabapentin combinations. They may be more toxic than we've led to believe over the last 20 years.
Yeah, and I think you're right. I think now that there's this big push by the CDC to avoid opiates, I think you're exactly right. A lot of patients are getting started on gabapentin or Lyrica, and then, you know, they may see another provider who gives them an opioid and they don't realize that there's that risk. Unfortunately, gabapentin doesn't come up on the PMP. Lyrica does, since it's a Schedule 5, but unfortunately, you don't see gabapentin on the PMP to know that a patient is taking it.
And Dr. Chuang, did you have a question as well?
Okay. Any other questions on that? Okay. Well, let's get back. So step 6, you want to do a risk assessment. Basically, you want to have a document. You want to document any substance abuse history, whether that's alcohol or illicit drugs or prescription drugs. That's very important to do. And if we look at the new bill 474, it's actually saying that if you're going to have patients on medications longer than 90 days, you have to do some validated risk assessment to track if the patient may have an opioid use problem. In our clinic, currently we're using the ORT. So what we're doing is we actually, at the initial appointment, every new patient we see, we're actually utilizing Dr. Lewandowski's MSQS, the Medical Stability Questionnaire. And inside of the MSQS, the patients don't realize it, but we have the 4 questions for the ORT in it, so they don't realize that we're actually getting at substance use disorders with those questions. So when we get the MSQS results, it kind of breaks down into 2 different categories. One would be, the Medical Stability Questionnaire, are they mild, moderate, or high risk for treatment? And then we also get the ORT, which tells us if they're mild, moderate, or high risk for opioid use. At their follow-up appointment, based off of the results of that, we see if behavioral health needs to be, a referral to behavioral health is appropriate to help intervene in that situation. I bring up the SOAP-R because that's another validated tool. It's a little bit longer. I think it's about 20 questions long. It also breaks patients down to mild, moderate, or high risk. And when I was doing reading some articles on urine drug screening and assessment tools recently, there was a best practices paper out of Texas, and they were talking about in the literature that the SOAP-R has the highest sensitivity of catching a patient with an opioid use disorder. Even though it's the most sensitive, it only will catch 78% of them. So there's still about 22% of patients that the SOAP-R will not catch who have an opioid use disorder. But according to the literature, that is the most sensitive assessment tool that a clinician can use. On top of those, there are other assessment tools that are more physician-driven. One would be the DIAR. It's a series of questions that you can answer based on your patient's or observation of your patient's behavior over a period of time. That'll tell you if they're mild, moderate, or high risk. And there's another one that's called the Cheval, which is about 5 questions that you can review a patient's chart, answer those questions, and it'll tell you, I only think if that patient's mild or high risk. Any question on assessment tools?
Can I ask a question to the audience? Why would you want to know if people were smoking cigarettes or smoking tobacco or vaping, smoking nicotine?
Hey, this is Barry Cole. I don't know if you can hear me. Yeah?
Yep, we got you.
Okay. One of the reasons I'm concerned about smoking is if you look at the CYP 450 system, that any smoking, even eating a grilled piece of meat, changes metabolism of certain opioids. Plus, we know that people who smoke, especially people who have to smoke within 1 hour of awakening, are going to be more likely to misuse, abuse substances in general. So smoking can become a proxy marker for potential substance use, misuse, just as we know mental illness in a patient or any of their first-degree relatives is going to be correlative with potential for misuse and abuse later on in the patient that you're treating. So all of these factors are actually kind of interrelated.
That was brilliant. And another thing is impeding the blood flow with smoking, which impedes the oxygen, which goes to like lower back pain. That's from the spine. Spine doesn't get a lot of oxygen anyway, and so we're impeding that. Then also with the smoking, we're looking at all-encompassing, because smoking affects everything in the body, and everything seems to affect chronic pain. And so when we're putting in smoking into the mix, you have insomnia, you have stress, you have all kinds of things that are cascading down through this one activity, let alone the carcinogens. And then when somebody is smoking, they get an immediate dopamine release. So they're recognizing pain relief with that. Even though it's a short-term pain relief, it is a dopamine release, and they do recognize that they feel that. So they're correlating relief with smoking, which is creating, again, another cascading effect with all kinds of different behaviors.
Yeah, that's true. And yeah, I think you're exactly right. You know, microvessel disease is one of the main causes of ongoing lower back pain. And so a lot of patients who smoke, they're not getting the nutrients, you know, to their spine that are necessarily to have a healthy spine. And so stop smoking can definitely improve lower back pain because the blood vessel flow or the nutrient flow through those small microvessels improves.
And the thing is, you know, a lot of people will go to vapes, which is also, people don't kind of get is that people are not addicted to the carcinogens in the cigarette smoke. They're addicted to the nicotine. And that's what they're getting in the vape pen. It's pure nicotine. So it's a very poor substitute for inhaling. Anytime you inhale any kind of smoke, American Lung Association doesn't like it. American Medical Association doesn't like it. So avoid smoke.
Okay. Any questions on risk assessment or any points people want to make? But I think the key point to be made here is with the new Bill 474 is that if you're going to continue to prescribe greater than 90 days, they're requiring that you do some type of peer-reviewed risk assessment on the patient. And the bill, or all the handouts that I've seen regarding the bill, they actually point you to your medical board's websites, saying that the websites will contain different risk tools that you can use. Okay. So step 7, physical examination of the painful area. And I think this is common sense. So the patient comes in and complains of lower back pain, you know, you have to assess the lower back. You have to examine it. You can't not have an examination of the painful area that the patient complains of. I've actually been utilized by the medical board in the past to review records of other physicians and their opioid prescribing habits. And one of the main observations I've seen in the docs who've gotten in trouble was, you know, I'd review their records and they'd have no examination of the painful area. You know, the patient would come in, complain of lower back pain, and they'd have a respiratory, cardiac, you know, examination, but nothing on the lower back. And then the plan would be to refill, you know, 360 Percocet for the month. And it would blow my mind that it would have no physical examination of the painful area. So you want to make sure that if you're seeing somebody for a pain issue, that you document some type of examination of that area. Step 8, you want to document documentation of the risk and benefits. And I think this is important because the CDC talks about looking at comorbidities that the patient may have. You know, does the patient have sleep apnea? Do they have COPD and are on oxygen? You know, I think a lot of times I see patients who come to me and they'll be on like 4 liters of oxygen. They'll say their pain is out of control and they're asking me to increase their pain medications, which are already at 90 morphine milligram equivalents a day. And I'm trying to explain to them, like, no, this is not in your best interest to increase any further. You know, you're already 4 to 8 times more likely to overdose once you get to 90 morphine milligram equivalents. And with your lung capacity, this is a disaster waiting to happen, especially with respiratory depression. You also, in our medication agreement, we have the material risks for every body system. You know, we talk about respiratory, how it can cause respiratory depression, how it can fragment your sleep cycles, how it can cause endocrine issues. And so I think you want to have those spelled out, and you want to have the patient actually acknowledge that they realize that this can cause endocrine, you know, all these respiratory endocrine, you know, issues that can occur. I saw a patient once who's on high-dose opiates. He'd seen an endocrinologist for hypotestosteronism, and first moment I met him, he said the workup was negative, and I said, well, I can tell you what's causing it. It's your high-dose opiates. Like it can cause, you know, your testosterone to be suppressed. So I think you want patients to realize the pain medications they're taking, you know, not only help their pain, but they're causing other parts of their body to have consequences. And so I think the comorbidities are very important to list, because if you're going to consider increasing your medications on your patient, you know, you want to make sure that the benefit outweigh the risk that the patient may have. Any questions on that? Okay. Or, I mean, for your peace of mind, you know, if they do have a lot of comorbidities, in your mind, probably the risk of increasing the medications aren't worth the benefit that the patient may have, and you may want to explain that to the patient. Step 9, I guess this one is the don't be a hero step. And basically, any patient that you're seeing, you should make an appropriate referral for addition, evaluation, and treatment. So if somebody comes to you complaining of abdominal pain, you probably should send them to a GI specialist to have a thorough abdominal workup. Just don't put them on pain medications and continue them without evaluating what's going on. Step 10, you want to get an updated board of pharmacy review. So our clinic, we're actually probably on the stricter end of things. Every new patient we see, whether they're coming asking for pain medications or not, we get a P&P report on the patient. And then every follow-up patient, any patient who's on a controlled substance, we get an automatic P&P report at every visit. I think the previous law was saying that anytime you change the Medicaid before you started, or anytime the dosage changed, you're supposed to get a P&P. But I think now Bill 474 requires that as a provider, you get an updated P&P report every 90 days on a patient you're prescribing chronic opiates to. So the key is here is getting one every 90 days on patients you have on long-term opiate therapy. Any questions on that?
Yes, can you hear me?
Yeah, I can hear you.
I have 2 questions. Who do you refer to when you said refer to behavioral health? And second, I'd like access to forms that are state approved, not only by the new requirements for MDs under the medical board, but that fulfill the requirements of the nursing board, because I have mid-levels that work under me. I don't want to reinvent the wheel. We've been spending a lot of time trying to comply with these regulations and make appropriate forms. So it'd be great if we could have access to ones that are already compliant.
Yeah, so I will do this. Troy, if you send me a reminder, I actually took the time a few months ago to go through all the risk assessment tools. And I actually have kind of a description of every single one, and I have the attachment. What I can do is I can send that to you. And so it kind of has a description of each one.
Great.
You know, I can have each one accessible for you to use.
Great. Oh, how about the behavioral health referrals? Are you referring to psychiatrists, psychologists?
So in our clinic, we have an MFT. So she actually, her background is drug and alcohol addiction. And so if she's on the panel of the insurance, you know, I will refer within our practice to her. If she doesn't think she can handle that care, then she will refer outside to usually a psychologist or psychiatrist. If I don't think she can handle it, then I look at the patient situation. Do I think they need medications prescribed to them? If I think the answer is yes, then I'll send to a psychiatrist. If I think they need more cognitive behavioral therapy and less medications, then I'll probably refer them to a psychologist outside the practice.
Is that something, well, about 60% of my patients are Medicare. Is that something that Medicare is going to reimburse for behavioral, what is it? What's an MFT?
An MFT is a marriage family therapist.
Oh, okay. Is that something that they're going to have to pay for out of pocket if they're Medicare?
No, Medicare patients are usually their behavioral health codes that do cover behavioral health. And
okay.
So I think the catch that you get into is Medicaid. Medicaid may not have as good a coverage for behavioral health, or it's very tough to find a provider that will take your insurance.
Yeah, I'm not sure in our area, but I'll have to look around. Thank you.
Hey, no problem.
Sue, can I have your last name and I'll follow up with you by phone?
Yes, Sanchez.
Okay.
And I can give you my email right now.
Oh, that would be perfect, yeah.
SANCHAE, Sanchez at mac.com.
All right, thank you. I'll follow up.
Thank you.
Have you been part of
Oh, go ahead.
we're echoing.
Oh.
Have you been part of the form development, working with the state? I know that Dr. Stephanie Woodard and Dr. DeMuro have been working on basically forms for providers, and I believe nurses are included, that if you fill the form out in conjunction with the prescription for opiates, that then filling it out completely makes you compliant with AB 474.
Oh,
so
I heard Dr. DeMuro and his ECHO refer to that they're developing those documents, but I have not seen them yet.
They're very, very close. So once those are done, we'll be sure to post them as a resource on the ECHO website. But I believe Dr. DeMuro will be back in to do another follow-up on AB 474. So it is a resource for as far as forms go.
Okay. Yeah, so I would look for that. I mean, if you really want to make sure you're compliant with the law, and if they're creating forms incorporate into your EMR or your medical charts, I think that would be a great benefit, because at that point, you know, you're doing exactly what they're looking for.
Yeah, that was the intention, was to be able to put it in the medical records.
Okay.
Yeah, Sue, go ahead.
For those who don't know, we just ran into this problem. The nursing board last November made strict regulations for the nurses, which my mid-levels and I were unaware of. And that was put into place last November. So those of you who have mid-levels, make sure you check that out.
Okay, thank you.
It is very cool. I just want to bring up one thing that caught me by surprise for controlled substance prescribing, even at the state hospital system, that unless you pull a PMP under your own unique identifier, meaning your login and password, you're not showing up in the database as having pulled the report. So I had to call to the pharmacy board and explain, hey, the state hospital pulls a PMP automatically on every single admission. It's archived in the medical record if you ever want to see it. I've initialed it, I've dated it on the day I reviewed it, and they said, well, that would be okay if we audit your chart, but you're kind of making it harder for us when you don't pull it as yourself.
Yeah. Well, I know that they're definitely tracking. They can see when you log in, and then after you log in, they can see, you know, what you're searching for or looking for, is my understanding on the pharmacy end.
Right, but if you're in a hospital system or a healthcare system where you've actually set up like a requirement that everyone gets a PMP pulled at admission, then the problem will be it's not under your name, your identification. So when they try to see if you're complying with the law, since the law is changing under 474, you may want to now set up a practice where you personally will pull everything and not rely on the pull by an institution.
Yeah, that's a good point.
Hey, Dr. Cole, this is Kevin Flynn from Northern Nevada. What system do you have that's pulling it on a system level? Because I'm unaware that any EHR can pull it. I thought all providers had to log in uniquely as themselves.
Yeah, when I was working for Northern Nevada Adult Mental Health Services, we had the pharmacy pull the PMP as a matter of practice on every single admission. So it was being pulled, I believe, by one of the pharmacists at Northern Nevada Adult Mental Health. The actual printed copy was placed on the front of the chart. I and all of the residents I supervised, we would initial and date and make any comments or circle anything that we thought was of importance. And then that went in the hard paper copy to medical records to be digitally scanned. So again, it was being done through the Department of Pharmacy at Northern Nevada Adult Mental Health. You may wind up being asked to do it by your practitioners, because that's what the medical staff did, and we dumped it onto the pharmacy.
Well, I'm used to being dumped on a lot, so.
Exactly.
But I would be, because I'm in contact with the state board quite a bit. I've got a good relationship with them, and I know that they are looking for that individual prescriber. So, and it may come out in the wash later on that it's okay, but as far as I know, that it has to be that digital signature. And providers, what I've seen historically, both at Carson, where I used to work, and then also here in Northern Nevada, they would oftentimes, you can designate someone as your authorized prescriber, authorized call-in to utilize that functionality to access the PMP. But I'm just not aware that there was systematic pulling of it. So in short, the pharmacist would show up as the one retrieving the record. That's what you said had been done, correct?
I don't know that it was that the pharmacist was shown as the prescriber of record, but that it was being pulled institutionally by a member of the pharmacy staff at Northern Nevada Adult Mental Health Services. A hard copy was printed. That was archived in the paper record and then digitalized. And when I spoke with the Board of Pharmacy, they said that met the letter and the spirit of the law last year. I don't know if that would still be true under AB 474.
Interesting. Yeah, I'll dig deeper. That's a good point.
It'd be worth it for everybody, because it's going to matter if you wind up, because I got one of those letters that said, like, you're a bad doctor. You didn't pull the PMP report as required by law. I then called the pharmacy board and I said, oh, no. We do pull the reports on 100% of our admissions. It is archived in the chart. Myself and the resident who takes care of the patient have both co-signed the PMP report to show that we have systematically reviewed. They said that was okay.
Yeah. Clinically, it doesn't make a difference, but I'm curious about any legal issues down the road. But that's a very, very good point.
Yeah, and obviously 474 could be changing the dynamics, because that's now up the ante for the prescriber of record.
Yeah. And I have to say, like, some of the, prior to 474 and doing some of the medical records review for the medical board, I've seen situations where, I'm checking to see if the provider that I'm looking at the records, if they looked at the PMP, and sometimes the PMP is not in the record, in the medical record, or if it is, the provider never signed off on it. So did they acknowledge it, or was it pulled after the fact? And that's another thing to look at. When you do print it off, it does show the date that the timeline you pulled it for and what day you printed it. And on top of that, I always, just like you say, I sign across the top and put that date, so it's obvious what day I looked at it and signed off on it.
Can you hear me?
Yeah.
I'm glad you brought up 474. I happened to talk to the state head of Health and Human Services. His comment when I said, what are the penalties? Who's going to be the oversight? He said, what do you want me to do? You want me to be the policeman? You want me to put them in jail? So I'm asking you, who does the oversight? I guess it's the Board of Medical Examiners. There again, we have separate licensing boards, one of 13 states. Who does all? And what are the penalties? I've been in Nevada almost 50 years. I am amazed with the lack of penalties. If I'm seeing 20, 30 patients a day, I don't, thank God, anymore. But if I am, I may not do all this compliance, because I know even if I get called on the carpet, it's going to be a slap on the wrist.
Yeah, I think you're right. I think that's one of the problems with the state is, I think, lack of state funding. They don't have anybody to enforce it. And I haven't seen anything on it. I think what they're relying on is the medical board. So if you get a complaint to the medical board, the medical board then will review your records to see if you've been compliant with the law. I think that's
Barry Cole's been in this a long time, as I remember. And how about it, Barry? Why don't you get after them to put in some meaningful oversight and penalties that are, non-negotiable?
Wait a second. I'm like retired. I don't want to like fight with the government of the state of Nevada. There's been some weird stuff that's happened in Nevada. Most of us have now forgotten. In a 2-month period, we were actually required by state law to put everyone in pain on opioid therapy, including people with known allergies to opioids. So what happens historically is the legislature thinks it has a good idea. It goes to Legislative Counsel Bureau. Those people do whatever they want. The medical board then finds out after the fact. In terms of who could really enforce this, good luck. It's going to be fractured because it's involving the boards of pharmacy, the osteopath, the allopathic boards, the nursing boards. There's like so many different groups that are involved, but legislature just writes law as if everybody's the same and doesn't understand all of the subtle differences. My suspicion is AB 474 will implement and then be revised as we start working with it and we realize what little glitches were left between the original legislative intent and what Legislative Counsel Bureau did to make it work on paper. So, expect changes to follow.
Thank you.
I think Dr. Cole is right. This is Kevin Flynn again. At least speaking for the Board of Pharmacy, it's a complaint-driven organization. So I think in the next few years, when you start seeing complaints and people brought before the board, when they've done the auditing, maybe you'll see examples set, and that may drive compliance. But again, all the state boards just lack the funding to actively police it.
Real quick too, going back to setting up your team or behavioral health team, I think it's a really good idea to quiz your person or find out where they are psychologically, or not psychologically, well, yeah, that's good, but theoretically as well as practically. You want to find out how they treat somebody who, because I'm a licensed alcohol and drug counselor, so I have to be real careful with the addiction term. People who are physiologically dependent doesn't mean that in their mind the best therapeutic word would be you're addicted to it. There's also psychological components of dependence. The reason that you're adding somebody in is because if they come to me, I work with psychiatrists and physicians, and when we're on a team and we're working together and they refer somebody to me, that's because I get to spend an hour with that person. The physician and the psychiatrist get to spend less time with that person. When I'm working with that person, we're working through the mechanisms of action, what that substance is doing in their body, and then what they can expect to happen, how they can expect to feel, how long it will last, that there's light at the end of the tunnel and it's not a train coming at them, that there's relief. But then also one of the ways that the medications keep hold of people is it gives them relief. And then on the other side, when they're getting it out of their system, they have the withdrawal symptoms. So they have a double whammy. If somebody's there to explain and walk through that with them, with some practical, healthy, fulfilling physiological coping skills, then they're able to get off of that stuff. And it takes a lot of heat off of the psychiatrist and the physician. Because if you just drop them off and say, no, we're not going to give you any more of this medication because we're told it's bad, and watch this, benzos are coming next. Do you think opioids are a big deal? Benzos will be next on the firing line. And then trying to get people off of that takes months, sometimes years of withdrawal symptoms. So this is what's coming. This is why you want to set up a team. It gets you off of the firing line. You're not the bad guy anymore, and it's a team approach. But make sure that the MFT or nurse or licensed alcohol and drug counselor has the same theoretical kind of approach that you do, know how they're going to take care of this person, and know what they're talking about. So there's a lot that goes into putting together your team.
Just got a couple of minutes, yeah.
Sue, please go ahead.
I was wondering if any of you old timers had some perspective for me, because I was first licensed in Nevada in the year 2000, returning here after getting educated elsewhere. And among the documents I had to read to get relicensed and take a test and everything was a document that said if you don't relieve your patient's pain, that you are subject to disciplinary action. So does anybody have any historical perspective as to where that came from and who's responsible for that? And now we have a 360-degree turnaround.
Yeah, that initially came from the push in the 90s as pain is the fifth vital sign.
Right.
And I think there was such a movement back then to treat pain that the medical boards adopted that. And I mean, you could almost be sued by your patient too if you didn't adequately address it. But I think now the pendulum has swung the other way, that we've seen the consequences of pain as the fifth vital sign. And now I think the medical board is more worried about patient safety than they are about pain relief. That's kind of where that came from historically. So I think nowadays, I think you wouldn't be faulted for not increasing a patient's pain medications if you document why and put in your record that you thought it was unsafe to go any higher, and possibly even document what alternatives you recommended. A lot of times I've seen patients, I'll recommend alternatives and they'll refuse to do them. And so I'll just refuse to increase their opiates and tell them that we need to look at a different strategy, and I'll document.
We've kind of just stopped doing opiates altogether. I mean, the regulatory environment for us is just getting too onerous, so we just kind of stopped doing it. And we're freaking everybody out. We're going to stop pretty much giving benzos or opiates anymore. It's just, in a practice where you have to see 4 patients an hour to make a living, we can't comply with that. So we're just stopping it. So
yeah, I think a lot of practitioners are doing that.
This is Len Chrysler. I gave up that long time ago, and I don't know where that came from, that, you got to relieve pain, but I can guarantee you nobody paid attention to it in Southern Nevada. I never heard of anybody being brought on a carpet because they didn't take care of somebody's pain.
Yeah.
Hey, just before you give yourself too many pats on the back, the People's Republic of California was responsible for why we in Nevada got this goofy stuff. There were 2 lawsuits in California where physicians were literally hauled up into civil court and sued for failing to relieve pain in terminally ill patients, and their malpractice didn't cover them. I actually know one of the 2 doctors. It was really egregious. Another colleague in Oregon was censured by the medical board because in hospice he used codeine and he didn't use morphine. Go figure, somebody didn't know codeine is metabolized to morphine. What we got in Nevada was sort of like this confluence of what was also going on around us. And in the state of California, they passed a mandatory rule about 15, 20 years ago that said you had to get 12 hours of pain and end-of-life education. And believe it or not, that was negotiated down from 20 hours. So the original intent of the legislature give us 20 hours of education. We negotiated it down to 12. But the people that were bringing these lawsuits against the physicians in California were coming out of Seattle, Washington, and they were causing havoc in what was then the Ninth Circuit Court of Appeals, and Nevada is part of the Ninth Circuit Court. So I think what the medical board tried to do was align itself with where everything was going around 2000. Remember, that's when we had the obligatory requirement anyone with pain for 2 months had to be given an opioid in the state of Nevada until we realized what LCB did behind the Nevada legislature. So yes, today times are changing. Now we're worrying about everybody dying from opioids. But if you go back 15, 20 years ago, nobody prescribed opioids, so nobody was dying and everything looked great. We didn't screw up. We just played the ball where it was in the year 2000.
Correct.
Go Purdue.
Well, it's 9 o'clock. You want to just pull, I'll just show the last two steps. And then my presentation is available online. But basically, step 11, is recommended. I recommend that you get a baseline, a drug screen on patients. If you look at mild, moderate, or severe, that's based off of your risk assessment of the patient, the ORT, the SOFAR, or any, if you use the Dyer. And Medicare, if you look at their LCD in the state of Nevada, they say that if a patient has a mild risk, that you should do 1 to 2 drug screens every 12 months. If they're moderate, you should do 3 to 4 every 12 months. And if they have a severe issue, risk, then you should test them 8 to 12 times a month. And last but not least, step 12 is that you want to have a signed opioid agreement on file for the last 12 months. And so if you're treating patients longer than a year, you want to make sure every year they re-sign that opioid agreement. And I think that's it. Well, hey, I appreciate the lively conversation. It's great to have people participate. I think it adds to the value of the experience. And so I want to thank you all for coming in and participating. Thank you.
Thank you so much. We'll be back on November 1st.
Thank you.
Thank you.
Thanks.